Zone 3 injuries are the mediastinal injuries, and because once the moment I say the mediastinal injuries, you will be aware that we are talking about a very serious zone, isn't it? So mediastinal injuries are basically injuries related to the um, trachea, bronchus, the large vessels, aorta, and the injuries in relation to the heart and the pericardium. Right. So there are various forms of mediastinal injuries which are to be addressed because they also carry a very high risk of mortality. To produce a mediastinal injury, it requires a very high force. It needs external fractures, or it needs some very high force on the anterior chest, or a transmitted injury to the mediastinal structures. So it needs a real shearing forces to rupture these organs. But once they occur, they carry very high mortality, and some of them a near 100% mortality. And one of the common questions asked for entrants as well as undergraduate students is sometimes called the aortic transection. Aortic transection is an entity which is produced by the shearing forces when the body is crushed or rapidly decelerating between the mobile aorta and the fixed portion of aorta. That is between the arch of aorta and the descending thoracic aorta. And it invariably occurs after the origin of the left subclavian. The most common site of aortic transection is after the origin of the left subclavian, and this carries a very high mortality because 30 to 50% the patient dies immediately. You don't even get a time to investigate. But when there is a slow rupture and there is a leakage, the investigation of choice, as shown in the picture, is a CT. Right. It is in the CT. It is a contrast that is the spiral CT, which will tell you exactly where is the lesion and where is the leakage. And there is no role for any conservative treatment. You need to you need to do emergency exploration, a rapid exploration, and then explore the arch of aorta and then repair the segment. So when you are planning for a repair, the most important thing in case of an aortic transection is you need a shunt between the proximal aorta. You need a shunt between the proximal aorta here, the proximal aorta here, and the distal aorta here. Okay, and then you repair the defect at this position. So you have to plan your intervention in such a way that there is a shunt disc between the proaortic arch and the distal aorta, and that is called as a GOT shunt, G-O-T-T shunt, and then you repair a patch repair of the aorta. That is what is done. But it requires an expertise as well as a quick intervention. Otherwise, the mortality ranges from 50 to 100% because it is a massive vascular injury which needs to be immediately repaired. The common MCQ question asked in this regard is, what is the most common site? Most common site is distal to the left subclavian. What is the best investigation? It is a spiral CT. These are the two things. Now coming to the next area, that is the blunt injuries to the trachea as well as the bronchus. It is one of the second most common injury to the mediastinum, and it produces, whether it is trachea or the bronchus, air is leaked, so it produces massive pneumothorax. Patient will have extensive surgical emphysema because of the huge air leaks, right? And it is a very rare cause of injury, but you need to act immediately. Tracheal injuries will be having massive pneumothorax, which is bilateral, extensive surgical emphysema, and stridor or hoarseness. Bronchial injuries will have extensive bilateral pneumothorax. You can have extensive surgical emphysema, and these patients will have dyspnea, right? They will not have any hoarseness or they will not have a stridor, but they can coexist, right? And tracheobronchial injuries is usually caused either by a shearing forces, or a rapid anteroposterior compression, or a rapid deceleration, or when the trachea is compressed between the sternum and the vertebral column, or when the trachea is already diseased, it can be by the necrosis induced by osteophytes. And where do you get the tracheal ruptures? The tracheal rupture usually occurs posteriorly through the cartilaginous zone, non-cartilaginous zone. That is the most common injury, but you can get it from any other area. And this both tracheal or bronchial injuries requires an emergency CT, emergency intubation if it is a tracheal injury, and patient requires an emergency surgical repair. Right? You definitely have to repair that the disruption of the trachea by an emergency intervention, and most often it is repaired on by surgery by using proline. The trachea is repaired using proline. Some cases you may have to persist with a tracheostomy, or you have to continue with endotracheal intubation. But they require emergency intervention because most of them are immediate life-threatening injuries. So the principles of management is immediate admission, emergency CT, bilateral intercostal tube for the new tension pneumothorax on both sides, put an endotracheal tube, take the patient to theater, and do an emergency repair. Either you do, if it is a neck injury, you explore the neck. If it's a thoracic injury, if it is a scarinal injury, median sternotomy. If it is any of the bronchus, you can choose based on the side of the bronchus. If it is right side, right-sided approach, left side, left-sided approach. But it carries a very, very high mortality. Now, coming to the next entity is the whenever we said about the importance of the life-threatening the nature of the tracheobronchial injury. And there is one sign which has been described in case of a bronchial injury that is called as fallen lung sign. That is because when the bronchus is injured, it falls down and the whole collapsed lung will appear a little more lower level than an expected level in a tension pneumothorax. Right? Tension pneumothorax, you will get it in as adherent to the bronchus, very close or higher up. But in case of a tension pneumothorax produced by a bronchial injury, the lung is falling down and that will cause a fallen lung appearance. Now so that actually completes the tracheobronchial injuries and the aortic injuries. Now coming to the most important thing, or the most commonly discussed, most commonly asked entity in mediastinal injury, that is cardiac tamponade. What is cardiac tamponade? What is the definition? Cardiac tamponade is a rapid accumulation of the blood in the pericardial cavity that impedes the cardiac motility. What is the effect? When it impedes the cardiac contractions, what will happen? It will cause hypotension, isn't it? And the patient will go for hypotensive arrest. So how will you manage? You manage it as aggressively as possible, isn't it? You manage it aggressively. You manage it in such a way that these patients has to be admitted in an intensive care unit. Now, how much amount of the blood is required to produce a cardiac tamponade? The amount of the blood that is required to produce a cardiac tamponade is 50 ml. You know, in pericardial effusion, you can even up to 500 ml. But the rapid accumulation is the key way. So, amount of even 50 ml of blood in the pericardial cavity can cause a cardiac tamponade. So, what are the clinical features? How will you identify? The clinical features are very simple. The patient will have shock. That means patient will be hypotensive. Then what will happen? The pulses will be pulses paradoxes. Then what will happen? You will get an elevated JVP. And there is a classical triad of distended neck, muffled heart sounds, and hypotension is a classical triad of Beck's. And this is present only in 30% of cardiac tamponade. The Beck's triad is present only in 30%. So you don't have to wait till the Beck's triad to develop because that is present only in 30%. 70% of the patient will have cardiac tamponade and they will present with elevated JVP, and also they will present with hypotension, and if it is unaccountable, you have to always suspect. Now, so that is why the diagnosis of pericardial, the cardiac tamponade is important, and normally with the use of extended fast, it is very easy to identify a pericardial tamponade by putting a subxiphoid probe, right? That will identify whether there is a blood in the around the cardiac chamber. And how will you diagnose it concurrently? or by what is the diagnostic investigation of choice? Diagnostic investigation of choice for a pericardial tamponade is a 2D echo. The echo is a diagnostic investigation, and once you do that and you confirm there is a pericardial fluid, the most important treatment is an emergency pericardiocentesis. How will you do an emergency pericardiocentesis? Emergency pericardiocentesis is a measure which is to be known to all emergency room physicians. And what do? You actually attach the patient to all the ECG monitors. Then you take a number 16 cannula and approach through a subxiphoid route. You approach it through a subxiphoid route, right? And in the direction of an apex and 45-degree angulation. You go on aspirating, and the moment you strike the blood, you aspirate and see whether the blood is clotting. If it is not clotting, that means you are in the pericardial sac, not in the cardiac chamber. The moment you touch the cardiac chamber, then you will have the fluctuation of the ECG. So you have to always attach the patient to an ECG monitor or a multipara monitor to see the fluctuations on the ECG, because that will induce arrhythmia. And pericardiocentesis is a life-threatening procedure, and every emergency room physician should be competent enough to do a pericardiocentesis. So how will you, so cardiac tamponade, you need to say the definition, you need to know the pathophysiological effects, you need to know the clinical examination. Beck's triad is a short note. Beck's triad is present only 30%. That's an MCQ question. Investigation of choice is a 2D echo. The treatment of choice is emergency pericardiocentesis. If it is a massive pericardial effusion, that is the time, then when, or massive pericardial tamponade, that is the time you do an emergency room thoracotomy. Now coming to the next entity, the myocardial injury. Myocardial injuries can be a myocardial contusion, a chamber rupture, or it can be a complete heart rupture. The third entity, the patient will not survive. The second entity is also a ventricular chamber rupture. Sometimes the bleeding is contained because of the thick muscles. A patient may be salvageable, but again it carries a 70 to 90% mortality. But myocardial contusion is one thing you should always remember at the bottom of your heart or bottom or inside your brain at all possible locations. It normally occurs when there is an anterior chest wall compression and there is a sternal fracture. What will happen? It will compress the myocardium and induce a contusion onto the myocardium. What will be the clinical presentation? The clinical presentation is classic. Hypotension with bradycardia. Hypotension with bradycardia, whenever you find, think about myocardial contusion. Because normally when there is hypotension, you get tachycardia. But hypotension with bradycardia is one sign of a patient with a myocardial contusion. So you are suspecting myocardial contusion. How will you diagnose? It is just like an MI. So what will you do? You take an ECG. And when you take an ECG, you will find that there is an acute injury pattern in the form of an ST segment elevation on the anterior leads, as well as you can get a bundle branch blockage and sometimes an atrial fibrillation. Okay, you can also you can also send enzymes of troponin I or troponin I to see whether there is a enzymatic evidence of myocardial contusion, and the patient has to be aggressively monitored because this patient can go for irreversible hypotension. You have to be very careful in these patients with the fluid management. There is no point in pumping in the fluid because the pump is not working, right? So you have to be very judicial, but you should be highly aware that there is this entity whenever the patient present with hypotension and bradycardia, think about a myocardial injury, right? So ventricular laceration, I said, it's a life-threatening thing, and the patient will require an emergency intervention. There is no time to waste in case of a ventricular laceration. You have to go in and repair it as early as possible. Now, what are the indications with the emergency department thoracotomy? Emergency department thoracotomy is basically a resuscitation thoracotomy, like evacuation of pericardial tamponade. There is removal of or control of pericardial or the thoracic bleed, perform open CPR, repair cardiac injuries, And also when there is an aortic transection to cross clamp the aorta or cross clamp the trachea, right? It is done as an emergency. It's not a real procedure that is definitive. You have to take the patient to theater, but the basic idea of controlling the patient in from before dying. And now even the recent protocols say that emergency thoracotomy has got a survival rate of 15% in patients who are likely to be lost. That means 1 in 6 can be saved. So the role of emergency room thoracotomy is coming back to practice, and that is that is why I wanted to address the indication for emergency room thoracotomy. Now coming to the next or the last entity, the penetrating injuries to the thorax. We said whenever there is a penetrating injury, the most important thing you have to remember is if it is an anterior injury between your nipple line or between the mid-clavicular line on either side and from suprasternal notch to the xiphisternum, always assume the mediastinum is injured and you have to explore it. And there are certain principles. Never ever try to pull off the knife or the penetrating object. You have to remove the penetrating object only when you transport the patient to a theater scenario. Resuscitate the patient, arrange the blood, take the theater, intubate, give anesthesia, then do a thoracotomy, and you need to see the tip of the instrument as you take out the instrument. Otherwise, what will happen? The tip of the instrument may be causing tamponade to stop the bleeding. As you take it off, it will lead, the patient will exsanguinate by rapid bleed. So you should have a direct control the tip of the instrument before you take out the stab knife for whatever penetrating object. So there is always, we have taken a lot of impairment injuries, and you have to, the only principle is the end or the tip of the penetrating object has to be visualized before you take it out. And that applies to the penetrating injuries of the chest also. And most of the 90% of the penetrating chest injuries, when that has to be explored. And whenever you talk about penetrating chest injury, what I wanted to tell was whenever the pleura is injured, that is when you call it as a penetrating chest injury. Just like when the peritoneum is injured, you call it as penetrating abdominal injuries. When the platysma is injured, you call it as penetrating neck injuries. But when the pleura is injured, you call it as penetrating. And it always requires emergency resuscitation, as I said in ABC lines, intercostal tube, resuscitate and blood arrangement, intubate, ventilate, and explore. And with the tip of the instrument in view, you pull it out. Now, when I say exploration, what is the mode of exploration? What is the best thoracotomy? The best thoracotomy of the trauma is the anterolateral thoracotomy. Whenever in case of thoracotomy for trauma, always prefer an anterolateral thoracotomy, usually performed at the fifth rib. That is the best thoracotomy for a trauma. But is it all the time? But whenever you have an MCQ question, it is an anterolateral thoracotomy. Now, if it is a mediastinal structure, what will you do? You do have to do a midline thoracotomy or median sternotomy. So, based on the site of injury, you plan either a left anterolateral or the right anterolateral or median sternotomy. For example, when there is an anterior aspect of the heart is injured, the carina is injured, the trachea is injured, the pulmonary artery is injured, the aorta is injured, you have to go with an anterior thoracotomy. That is a median sternotomy. But if it is a left-sided structure in the form of a left lung, left bronchus, left hilum, thoracic aorta, the left heart, the esophagus, you go for a left thoracotomy. If it is a right-sided injury in the form of ascites vein, the esophagus, the mid-esophagus, superior vena cava, then you will have to go with a thoracic trachea. Then you have to go with the right-sided thoracotomy. Carinal injuries are always approached to the median sternotomy, right? And so, based on the site of injury, you decide on what thoracotomy, the right and the left, or the median sternotomy, and that is always an MCQ question. Now, last but not the least, there is something called as emergency room thoracotomy, which I already said, and that is approached through the left fourth intercostal space to give internal cardiac massage. Right, you go directly in, open up, and then give internal cardiac massage. And there is something called as clamshell thoracotomy. It is normally we don't do a transverse thoracotomy, isn't it? But clamshell thoracotomy is done in trauma scenario when that was done previously. Now nobody does clamshell thoracotomy that often because it is just because you are ruling you can't actually find out where is the bleeding, and you're opening both thorax and the mediastinum together with a single incision right from the anterior axillary fold on one side to the anterior axillary fold on the other side, just below the nipple line in the fourth or the fifth intercostal space. Open up the pleural cavity as it is. Nowadays, transverse thoracotomy is not done that commonly, but this is called as a clamshell thoracotomy. So what I've been discussing is in detail about the chest injuries, the zones of chest injuries, and the management of chest injuries based on the zones and the different short notes. But what is a basic principle of any chest injuries, whether it's a blunt trauma or a penetrating trauma? Emergency resuscitation in the form of airway, breathing, and circulation. Right. Once you secure that is breathing in the form of a tube thoracostomy or an intercostal tube. Once you secure that is emergency resuscitation. You cannot wait for any investigation. Get a CECT and try to find where is the bleed or where is the injury. And based on the type of injury, you decide on whether to manage conservatively by a tube thoracostomy in observation or to go for an emergency thoracotomy. And when you do emergency thoracotomy, you decide the approach based on the injury you identified by your CT, like a right or a left or a median sternotomy, and then deal with the organ of injury, right? And again, I'm telling, if you do like that, you are actually preventing 25% of the post-traumatic deaths, because this is the most common cause of death in trauma. Thank you very much. So that actually completes the chest injury. Is a big, useful, high intensive topic where you will get a lot of questions on this, a short note, management question for postgraduate as an essay, different multiple choice question which we have discussed already in different headings, but we will again discuss MCQs along with the topic at the end of the topic again to give you an insight why you learned this. Right, so that actually complete this, and the next topic is we'll go for the neck injuries and then the blast injuries, and the last but not the least is the reimplantation and the revascularization. Thank you.